Good morning, everybody. Good morning, good afternoon, good evening, depending on where you are. Thanks for joining us today. I'm Dr. Ophira Ginsberg. I'm Senior Advisor for Clinical Research at the U.S. National Cancer Institute Center for Global Health. In 2021, in commemoration of the Center for Global Health's 10th anniversary, we launched the NCI Global Cancer Research and Control Seminar Series. In this series, we feature talks by researchers and cancer control experts working in global oncology and provide opportunities for discussion and collaboration around impactful and innovative work that addresses cancer morbidity and mortality worldwide. In today's session, I'm very happy to welcome Professor Kumar Prabhash. The development of systemic therapy, including clinical therapeutic trials in the Indian setting, provides and presents unique challenges, but also opportunities. Professor Prabhash is a leader in the effort to advance innovative approaches to cost-effective and equitable cancer care, such as low-dose immunotherapy. In this seminar, Professor Prabhash will discuss some of the exciting work from his group that highlights these opportunities and solutions. Professor Kumar Prabhash, MD, DM, is a medical oncologist and professor at Tata Memorial Hospital in Mumbai, India. His interests lie in head and neck cancer and lung cancer, especially the development of cost-effective treatments. Professor Prabhash has authored more than 400 publications. Before turning things over, though, to Professor for his presentation, I'll go over a few logistic items. Please note today that today's presentation is being recorded and will be available on our website at cancer.gov/, global health. You can find information about future presentations on our site and by following us on Twitter at NCI Global Health. Questions will be addressed during the designated Q&A time immediately following the presentation. During that time, you may either use the raise hand feature found under reactions in the Zoom and wait to be called upon, or to type your question in the chat box. But if you are called on, please unmute yourself and ask your question. And now we'll begin our presentation. Welcome, Professor Prabhash.
Good morning, good afternoon, and good evening, as you suggested, whichever part you are from. And at the outset, I am thankful to NCI for this opportunity to allowing me to speak today. And my topic for today's presentation is development of systemic therapy in head and neck cancer in Indian context. So there will be a lot of features where Indian context comes into the play. The way I have done for my talk is that rather than talking one of those projects, I've tried to give the flair of things, what we do in our group here at Tata Hospital and our group. So I've got three buckets of work which we did for three different problems and providing solutions in those situations. One is borderline resectable oral cavity cancer, a unique problem from our subcontinent. The systemic therapy in chemoradiation, to try to find out which systemic therapy is best suited in these patients, especially in our patients. And palliative systemic therapy, as highlighted that low-dose immunotherapy and metronomic approach so that this can be given to majority of the patient, and then summing it up. Starting with the borderline resectable oral cavity cancer. Everyone who deals with oral cavity cancer will suggest that if you can remove it, that is resect it, that's the best possible treatment for this patient. But if you can't remove it, then in locally advanced big tumor, they are primarily palliative treatment in this setting. And this is one of those problems which is fairly common in our subcontinent. You do have tumors which are big enough, and there is a question regarding, can we resect them as far as the margins are concerned? And that brings out one of those situations where we call it borderline resectable oral cavity cancer. We'll come to this more in later slides. But coming to resectability in oral cavity cancer, the resectability in oral cavity cancer is interplay between the clinician, the patient, and the disease. And we can see it here, the tumors which can be resected, considering the morbidity and the outcome, many of the clinician or majority of the clinician don't resect many of those tumors. And in this backdrop, our first activity was to define those patients and call them, which are those patients which are borderline resectable. This is a well-developed concept in pancreatic cancer. And this is our problem. So we got together in our DMG and the group, and we try to define which are those tumors where margin is an issue at the time of resection. And if the tumor comes down, there's a potential for them getting resected in future. So these were the tumors, which is up to zygoma. Second tumor, which is involving the high ITF, that is above the sigmoid notch. Third is tumor involving the vallicula, where one has to do a total laryngectomy to remove the tumor, and also the tumor which extends up to hyoid. And again, one has to remove the larynx to do the resection. After definition, we did have a project where we were giving neoadjuvant chemotherapy and trying to see, can we resect a group of tumor? This is the large publication. And before this, we had few of them which suggested that, yes, we are able to resect some of those patients who were borderline resectable initially if given neoadjuvant chemotherapy. In this large study, that is 721 patients, when the neoadjuvant chemotherapy was given, 43% of the patient underwent surgery, which were initially borderline resectable. If not, they had gone for the surgery, for the chemotherapy, then they would have received either palliative radiotherapy or systemic therapy or chemoradiation. In the patient who underwent surgery after neoadjuvant chemotherapy, the median survival was 19.6 months as compared to 8.16 months, with p-value being significant. And we take it at the 2-year survival, then the 2-year survival was 47% in patients receiving neoadjuvant chemotherapy who underwent surgery, as compared to the patient who could not undergo surgery. The 2-year survival was around 20%, highlighting that if we start with 100 patients in this group of patients, then 1/4 of the patient can be long-term survivor if we use this approach. If you would have not used this approach, then majority of these patients would have lived for 8 to 10 months. That is the average life they would have had if they would have gone for radiotherapy or systemic therapy in this setting. Now, this was a new concept in this setting as far as the oral cavity cancer was concerned. And this brought up many of those questions when this kind of concept was getting implemented in the clinic. That what happens to the margin when we are operating in the revised margin? What happens to the complications after surgery when we have given neoadjuvant chemotherapy? What happens to chemotherapy when we give radiotherapy after surgery in these patients once they have received neoadjuvant chemotherapy? What happens to compliance? And if we are giving those chemotherapy, which of the drugs are the optimal one? Starting with the margin, subsequently, we did the match pair analysis for the T4 tumor patient who underwent surgery upfront as compared to the patient who received neoadjuvant chemotherapy followed by surgery, again in the T4 tumor. What we observed, the positive and the close margin rate was similar in both the group, with p-value not being significant. It suggested that if we give neoadjuvant chemotherapy and we resect with the revised margin, then the margin positivity rate is not higher as compared to upfront surgery in our population. We also evaluated what happens to the complication rate after neoadjuvant chemotherapy and surgery, comparing similarly what we had done in the past group of patients, that is patient undergoing surgery upfront, comparing them with neoadjuvant chemotherapy followed by surgery in this T4 tumor. And it appears that major complications and minor complications were similar in both the group, suggesting that neoadjuvant chemotherapy doesn't increase post-operative complication in these group of patients. We also evaluated what kind of chemotherapy can be added to radiotherapy post-surgery in these group of patients. It appears that we were giving cisplatin, and it appears that if you give cisplatin, that is weekly here, almost 22% of the patients, they do develop kidney dysfunction of grade 1, 2, or 3 in these patients. And this brings to the question to develop a group of systemic therapy in this situation, which is beyond cisplatin, because cisplatin does lead to significant kidney toxicity in these patients. We also evaluated the compliance with neoadjuvant chemotherapy. We evaluated the place, person, socioeconomic status, and the assistance given to the patient, and does that impact the compliance? It appears none of these individual factors predicted the non-compliance in these patients, but we did have 18.7% of the patients who were non-compliant, highlighting that we need to work with our patients to improve compliance with various other means. We also evaluated what are the chemotherapy which is useful in this setting, and do we have the comparison? So we compared 2-drug combination chemotherapy, that is docetaxel and cisplatin, as compared to docetaxel, cisplatin, and 5-FU. And it appears if we give this 3-drug combination of docetaxel, cisplatin, and 5-FU, they are better as compared to giving only docetaxel and cisplatin. The 2-year overall survival was 23.5% in docetaxel cisplatin as compared to 29.1% with hazard ratio 0.81 and with the p-value being significant. But it does appear that if you give this 3-drug combination chemotherapy, it comes with a toxicity, and febrile neutropenia rate is 23.2% in 3-drug combination chemotherapy as compared to 2.6% in patients who received doublet chemotherapy in this setting. And as we see that 3-drug combination chemotherapy is better than 2-drug combination chemotherapy, but it also highlights that we need to develop safer chemotherapy in this setting for our patients. These all the results also got validated with our recent presentation at ASCO, where we presented the data of more than 3,000 odd patients treated with a similar approach. And what it showed that if we do surgery after neoadjuvant chemotherapy in this group of patients, they have better survival as compared to who couldn't. So making these patients resectable has a value. Patient with pathological response rate, that is, was better as compared to who didn't have a complete pathological response rate. Again, 2-drug was inferior as compared to 3-drug combination in this setting. Shifting gear, that is shifting from borderline resectable oral cavity cancer to resectable oral cavity cancer, and also a concept of organ preservation in oral cavity cancer. There are 2 randomized trials in this setting, and it suggests that if we give neoadjuvant chemotherapy, in both these randomized trials, it was a negative study for overall survival. Well, one of the study done by Lisa etc. suggested that mandible resection rate was lesser if neoadjuvant chemotherapy was approached, and it was 21% less as compared to if the patient has not received neoadjuvant chemotherapy. This was important information for us, and we started looking for it, which are those situations where it can be useful. So this is one of the situations where you have the tumor just next to mandible. It is not involving the mandible, and because of the median margin, one has to remove the mandible. That is, segmental mandiblectomy has to be done. But involvement of mandible shouldn't be there clinically and also radiologically. And this was one of the situations which excited us to see that can we have a neoadjuvant chemotherapy approach to shrink the tumor and avoid mandibular resection. We do know that if we do mandibular resection, it does impact the appearance, the quality of life of the patient, and the speech and the swallowing. This led to the phase 2 randomized trial, where we compared upfront surgery in these group of patients where they underwent resection, that is segmental mandibulectomy, as compared to another group of patients where they were given neoadjuvant chemotherapy with docetaxel, cisplatin, and 5-FU, and they underwent surgery subsequently. What we observed, this was a relatively small trial, that if we give neoadjuvant chemotherapy in these patients, then almost 47% of the patient one can salvage or have mandibular preservation in these group of patients. And this came with local regional failure rate, which was similar in both the arm, and also disease-free survival was similar in both the arm. So patient outcome was not compromised, but organ was preserved, highlighting that yes, this approach can be used to preserve organ oral cavity cancer. Coming to this concept which we developed and its adoption, this concept suggests that in borderline resectable oral cavity cancer patient, there is a small group of patients can get curative treatment and they can be long-term survivors. In organ preservation protocol in oral cavity cancer, it appears neoadjuvant chemotherapy may help potentially preserving organ if used appropriately, and that needs to develop further. This concept has been widely adopted in India and in the subcontinent, and this is part of our Indian ICMR guidelines, the National Cancer Grid Guideline, OCTF guidelines, and other various publications. This is also part of our regular management at our hospital. We also have observed that slowly it is getting included in many of the international textbooks and the publication suggesting that has been slow but increasing adoption of this concept. Moving on to chemoradiation and the systemic therapy. We do know that chemoradiation plays a very important part in management of head and neck cancer. And systemic therapy becomes integral part with radiotherapy. Whenever we talk about chemotherapy, we always talk about this meta-analysis, which suggested that chemotherapy, when used with radiotherapy, provides the maximum benefit. This meta-analysis also suggested that 3-weekly cisplatin with radiotherapy is the treatment which gives the best care and should be considered standard of care. Various randomized trials also suggest that this may be the standard of care, but 50% of the patients, they were not able to take all the 3 planned doses of cisplatin. In this situation, there is a wide acceptability of weekly cisplatin, which is attractive, but there are very limited data available till recently. And this led to us to embark upon the randomized trial, which is cisplatin once in a week, as compared to 3-weekly cisplatin with radiotherapy in this setting. And this was a non-inferiority trial where the patient were supposed to receive radiotherapy. This was a trial schema. The patients included were 70 years and less of age, the squamous cell carcinoma of head and neck, excluding the nasopharynx, stage 3 and 4 tumor. Adjuvant and definitive both group were included. In the post-operative setting, the patient with high-risk features were included. The patient who had induction chemotherapy were not included, and patient had required to have adequate organ function. Patients were stratified as per T group, N group, and treatment intent, and patient randomized for 3-weekly cisplatin of 100 mg per meter square day 1, day 22, and day 43 with radiotherapy. In the other arm, the weekly cisplatin 30 mg per meter square with radiotherapy was included. This remains, and this was the largest study at that time, and today also in this situation, this remains the largest study. The outcome of the study suggested that for the primary outcome, that is local regional control, the 2-year local regional control was 58.5% in weekly cisplatin arm, as compared to 73.1% in 3-weekly cisplatin arm, with p-value being significant. Hazard ratio was 1.76, with the absolute difference in local regional control being 14.6, with the 95% confidence interval, 5.7 to 23.5, and it breached the boundary which we had set for non-inferiority, that was 15%, suggesting that weekly cisplatin of 30 mg per meter square was not non-inferior to as compared to 3-weekly cisplatin. As far as the other endpoint were concerned, that is the progression-free survival and overall survival, it appears that weekly cisplatin was similar to 3-weekly cisplatin. Now, these data suggest that which drug combination one can use in the clinic to provide the optimal care for these patients. Subsequently, we wanted to improve our outcome beyond cisplatin, what we had achieved. We do know that chemoradiation improves outcome as compared to radiotherapy in head and neck cancer. But if we see the progression-free survival data, it suggests that a lot more needs to be done in these patients to improve outcome if we want to have a better outcome, meaning there is an unmet need in this setting. This led to a randomized trial. That was a phase 3 randomized trial comparing cisplatin with nimetosumab, that is EGFR inhibitor antibody, as compared to cisplatin alone with radiotherapy in both the arms. Now, this was the trial schema, that the patients which were adult, that's 18 and above 18 years of age, the squamous cell carcinoma excluding nasopharynx were included, stage 3 and 4 patients with no distant mets were included, and patients who were fit for definitive CTRT were included. And also the patient should have had adequate organ function. Patients were stratified for TN, the site and the technique of radiation in this study. They were randomized between nimetosumab, that is 200 mg weekly, with cisplatin 30 mg per meter square with radiotherapy, as compared to weekly cisplatin of 30 mg per meter square with radiotherapy. 536 patients were randomized equally between these two arms. They were followed up weekly initially during chemoradiation, then every 3 months for 2 years, then every 6 monthly in this study. Progression-free survival was the primary endpoint, and the 2-year progression-free survival was 50.1% in chemoradiation arm, as compared to 61.8% in the patient who received chemoradiation plus nimetosumab, with hazard ratio 0.69, with p-value being statistically significant. The other endpoints like local regional control and disease-free survival also showed the similar benefit. But as far as overall survival is concerned, the hazard ratio was 0.84, but p-value was not significant in this study. Now, one of the questions which was there for this study was that at the same time, we had an RTOG study of 0522 with a similar approach. And again, EGFR antibody cetuximab was used. The question was why our study was positive as compared to RTOG 0522, which was a negative study. What we see here that in RTOG 0522, all the subgroups where there was a trend towards benefit were the group of patients which were included in our study. And we see it here that HPV negative patients were 94% in our study as compared to 26.8% in RTOG 0522. Hypopharyngeal cancer were more in our study, and also larger tumor was more in our study. As far as the treatment delivery was concerned, it was better in our study. That's radiation interruption was 34% in our study as compared to 51.8% in RTOG 0522. And also delivery of cisplatin was far better. And these were the various reasons why our study was positive as compared to RTOG 0522 study with cetuximab. We also did a subgroup analysis to see what happens to HPV negative patient. And in this study in oropharyngeal cancer, a patient, it appears that it improves survival in this setting, but this was hypothesis generating outcome. Moving a bit beyond cisplatin, because we do know that good number of patients are cisplatin ineligible. And in our practice, what we see that 1/3 of our patients are cisplatin ineligible. And we were looking for what are the treatment options we can develop in this setting. There are various criteria which are primarily consensus-based rather than evidence-based, suggesting absolute contraindication and relative contraindication for cisplatin. These are the various criteria which is used in the clinic and also in the various studies when we include the patients for cisplatin as a cisplatin eligible in chemoradiation trial. And if we see the treatment options which is available for cisplatin ineligible patient, they are docetaxel plus cetuximab, carboplatin plus 5-FU, carboplatin plus paclitaxel, and immunotherapy. If patients are not fit for any systemic therapy, then one can give accelerated radiotherapy in this setting. But I need to highlight that none of these combination or drug which I'm showing here, which is commonly used in this setting, has ever been explored in cisplatin ineligible patients systematically. And that led to our work in the patients who are cisplatin ineligible patients, where we explored docetaxel as a radiosensitizer, where the patient was not fit for cisplatin. The selection criteria was adult patient, 18 years and above age, ECOG performance status 02, locally advanced head and neck squamous cell carcinoma, adjuvant and definitive both patients were included, and patients were supposed to be cisplatin unsuitable as we had seen earlier. They were stratified for site of the tumor, the type of radiotherapy, the T group, the N group, and the indication for radiotherapy. The endpoints were 2-year disease-free survival, 2-year overall survival. The quality of life was also part of the endpoint and also the adverse event. Docetaxel used was 15 milligram per meter square weekly intravenously to be given with radiotherapy 60 gray in adjuvant setting and 66 to 70 gray in definitive setting with the FACT-HN version 4.0, which was included as an endpoint evaluation in this setting. The 2-year survival in this study in the radiotherapy arm was 30.3% as compared to 42% in radiotherapy plus docetaxel arm, with hazard ratio being 0.67 with p-value being significant. For overall survival, the 2-year overall survival was 41.7% in radiotherapy arm as compared to 50.8% in radiotherapy plus docetaxel arm, with hazard ratio 0.747 with p-value being significant. As far as the adverse event was concerned, it was far more in patient receiving docetaxel plus radiotherapy. The mucositis, which was 22% for the grade 3 to 5 mucositis in radiotherapy arm, jumped to 49.7% in the patient receiving docetaxel plus radiotherapy, with p-value being significant. And this highlights that if we add docetaxel to radiotherapy, it does lead to increase in toxicity. But what we can see it here that majority of the patients were able to tolerate and complete treatment. So if adequately managed, it can be given in this setting. So for chemo radiation, what I can suggest with the data which is there from our study, that weekly cisplatin with dose of 30 milligram per meter square is inferior to 100 milligram per meter square of 3 weekly cisplatin for local regional control. Nimetuzumab added to cisplatin improves local regional control, progression-free survival, and disease-free survival in our head and neck cancer patients. And docetaxel is a viable option for cisplatin ineligible patients receiving chemoradiation for head and neck cancer. And I may add here, this is the only treatment which has been systematically evaluated in this setting and has been shown that it improves outcome in this setting. Moving on to the palliative systemic therapy and metronomic approach for our head and neck cancer patients. We do know that we do have immunotherapy and cetuximab as one of those standard of care in this setting. This is the data from our hospital, and which suggests that immunotherapy in 15,000 plus odd patients, when analyzed for who are the patient who can access it, then it appears that only 3% odd patient can access this treatment. And this brought to the fore that we need to develop treatment for our patients in this setting, which is not only accessible, that can also be delivered to the patients. And this led to one of the initial work. We had a phase 2 randomized trial comparing what we call low-cost oral metronomic chemotherapy. And what it means is you give 1/3 to 1/10 dose of chemotherapy, which is given frequently. And we compared this approach to intravenous chemotherapy in these in the patients with head and neck cancer treated with palliative intent. What we observed that if we give this chemotherapy, that is methotrexate and celecoxib here, as compared to cisplatin, that is IV chemotherapy, the metronomic chemotherapy was non-inferior to IV chemotherapy and potentially superior. Also, the quality of life was better in patients receiving metronomic chemotherapy as compared to IV chemotherapy in this setting. But it's also highlighted the response rate was 12% only with metronomic chemotherapy, that we need to develop far better treatment in this setting. But this treatment, which costs hardly around 500 odd rupees per month, can be delivered to any patient in our country. But this limited efficacy for response rate led to our effort to find out which drug combinations can be used to improve the response rate in this setting. This is one of the algorithm developed by one of our statisticians to have optimal biological dose for metronomic chemotherapy. Because we use in smaller doses, so we wanted to know how we can use the Bayesian approach to see that different drug combinations can be used and developed for our patients. And with this Bayesian approach, which we implemented in this phase 1/phase 2 study for what we call triple metronomic chemotherapy, where rather than having 2 drugs, we used 3 drugs. So the 3 drugs were erlotinib, 150 milligram daily, methotrexate, which we started with 15 milligram per meter square weekly, and we keep going down to find out which dose is optimal. And here, again, I want to highlight, because of that Bayesian approach and our whatever we had discussed earlier, we went to decrease the dose to find the optimal dose in this setting, and celecoxib 200 milligram BD. And what I suggested, the approach, this is what we used, and what we used in this approach was to have a clinical benefit and also biomarker, that was circulating endothelial cell, combined as a decision-making to decrease the dose further to find what we call anti-angiogenic window, which is somewhere in between here. It was 9 milligram per meter square, which came for our patient for erlotinib, methotrexate, and celecoxib. Here in the platinum refractory head and neck cancer patient, we had response rate of 42.9%, which was very good as compared to what we have seen with the historical control. Progression-free survival was good, that was 4.6 months, and overall survival was 7.17 months in this setting, highlighting that yes, we do get a decent responses, but responses were not sustainable. In the meantime, we did a phase 3 randomized trial to see that if this drug combination is better than the other treatment which is being used in the clinic. This is 2023 ASCO presentation, which was the oral presentation this year. The trial compared the oral triple metronomic chemotherapy, that is methotrexate, celecoxib, and erlotinib, as compared to the physician choice of chemotherapy. And it showed that yes, the overall survival was better with triple metronomic chemotherapy as compared to physician choice of treatment, which is available for these patients, and with the hazard ratio 0.5 and p-value being significant. But again, highlighting that we didn't have a sustained responses. And we started looking for what are the possibilities to include treatment to sustain response for our patients who receive this triple metronomic chemotherapy. This led to our low-dose immunotherapy trial in head and neck cancer. We do know from the immunotherapy trials that immunotherapy does lead to, in a significant proportion of patients, having a sustained response and a sustained survival. Now, we wanted to include and incorporate this approach for our patient. One of the challenges remains that these drugs are too costly, and if we use in the full dose, then it was not possible to do the study. And also, if we were able to do the study also, only 3 to 4% of our patients could have afforded it. And yes, that time we started looking for it. Can we use in different dose and different schedule these drugs as in combination of triple metronomic chemotherapy? And this was based on the phase 1 trial data for nivolumab. And what it suggested, if you give the nivolumab in the dose of 0.3 milligram per kg body weight as compared to 3 milligram per kg body weight, then the receptor occupancy remains similar. And when we use in 0.3 milligram per kg body weight, then the dose what is required for average Indian population is around 18 to 20 milligram for these patients. And this is one of those review articles we wrote at that time. And we used this basis to use 20 milligram of nivolumab for our next trial. And this trial compared palliative chemotherapy, that is triple metronomic chemotherapy, as compared to palliative chemotherapy plus nivolumab, that is 20 milligram. The patients included were 18 years and above age, head and neck squamous cell carcinoma, planned for palliative systemic therapy, and ECOG performance status 0 and 1. The primary endpoint was overall survival. Secondary endpoint was progression-free survival and quality of life and adverse event. And the patients were randomized 1:1 with stratification factor of site, the previous treatment, and time to failure. The palliative chemotherapy triple metronomic regimen was methotrexate 9 milligram per meter square, erlotinib 150 milligram daily, and celecoxib 200 milligram twice daily. That same protocol which we had developed earlier as in the phase 1-2 trial, and also did a phase 3 trial for the same. Nivolumab 20 milligram every 3 weeks were added in this study. Response was evaluated every 2 months with Excel scan imaging with the RECIST criteria for response rate, and adverse event was evaluated at the every visit the patient came to the OPD. The sample size was 1 year. Sample size in the standard arm was taken as 28.29%, and which we thought that it will increase to 43.29% within the treatment arm, with the type 1 error of 5% and type 2 error of 20%. With 1:1 allocation, we had one interim analysis as asked by the ethics committee. The sample size was 184. Study was stopped at the first interim when we had to do the first interim at the time when we had 75 events in these patients. And for that, the nominal P was supposed to be 0.006. This is the response rate data. And what we see here, the response rate increased from 49.3% in triple metronomic chemotherapy arm to 65.2% in the triple metronomic chemotherapy arm plus immunotherapy, with p-value being significant. For the progression-free survival, the 1 year progression-free survival improved from 3.2% to 27.5%, with hazard ratio 0.564 and p-value being significant in this setting. For overall survival, the 1 year overall survival improved from 16.3% to 43.4%, with hazard ratio 0.545, with p-value being significant in these patients. If we see the cost of the treatment, then as we use 1/10 of the cost, so this is not a rocket science, that the cost of nivolumab as compared to all other treatment option which is available in this setting, that is pembrolizumab, the nivolumab full dose, all the cetuximab, the cost was 1/10, for our group of patients. But then also it's to cost around 20,000 rupees per a month for our patients. This cost does not take into account the cost of administration, the adverse event, and the doctor visits, etc. for these patients, which adds to the cost in this setting. We also evaluated metronomic chemotherapy in many other places, and one of the places which we wanted to highlight was in adjuvant setting after chemoradiation or after surgery in recurrent tumor. And it does appear that in this setting, it does not work. And I wanted to bring this here because a drug working in one setting not necessarily works at every place, but many times clinicians in the high-risk group patient, they end up giving these treatment, which may not be beneficial, and there's a potential that they can be harmful. And what we see in both the study, the interventional arm is below the standard arm, suggesting that it is not a good idea to use this treatment in the setting. So what we can say about the metronomic approach and low-dose immunotherapy approach, that this is the first ever randomized trial in head and neck cancer patients requiring palliative systemic therapy, where the addition of low-dose nivolumab to metronomic chemotherapy led to improvement in overall survival. And it is an alternative standard of care for those who cannot access full-dose checkpoint inhibitor. Metronomic chemotherapy alone, that is a double metronomic chemotherapy or triple metronomic chemotherapy, or and low-dose immunotherapy provides options for alternate schedule of treatment to majority of the patient in the developing world. We do know that majority of people in developing world, they don't have access to this treatment. And that is where we think these are the treatment options which is available for these patients. In adjuvant setting, the current metronomic chemotherapy with methotrexate and celecoxib does not improve outcome, and that puts a challenge to develop different combinations and different schedules to see that we can improve outcome for these patients. Now coming to the team and the acknowledgements, Dr. Vanita Narona, she is a professor of medical oncology in our own department and dear colleague and friend, and she was instrumental and key in every effort I have shown, and none of them would have been possible without her being part of it. And starting from beginning, she was part of all the effort. Next one, Dr. Vijay Patil, again, professor of medical oncology. He was my first student, a friend and a colleague, and was instrumental in implementing many of these initiatives. We do know when we have these kind of effort, you have a whole lot of people who are part of it, who help in implementing it. And here just that I'm presenting it, and many of them could have presented similar or better than what I have done. And what we can see here, Dr. Amit Dutt from the lab side will be happy to present in future if we get a chance some of the lab work which we did together, apart from Dr. Amit Joshi, Dr. Nandini Menon, Dr. Ajay, Dr. Minit, and Dr. Rusha. And these are the coordinators, what you see here. And without them, none of the clinical trials are possible. In head and neck cancer, there can never be an individual effort. Apart from the people from the same department, you require people from various departments. That includes surgical oncology department, radiation oncology department, medical oncology, radiology, occupational therapy, speech and swallowing, whole group of people, nutritionists, and you can see whole group of people who are there. They were actively involved in all this work, and these would not have been possible without their active help. The three people which have been mentor for me, Dr. Rajan Badwe, he is our director here, and without his support, it was absolutely not possible to implement any of them. In the middle, Dr. P.P. Babsi, my guide and mentor, under whom I got trained, and Dr. Sripat Banavali, my ex-HOD, now current academic director, and a mentor for me. And again, I repeat, nothing would have been possible without these three people being there. Thank you so much. We'll be happy to take any question.
Wow. Thank you so much, Professor Prabhash, for a fantastic presentation. Very excited. I've got so many questions, but it's not up to me to ask all the questions. So we're open for questions. If you're able and comfortable, we invite you to please turn on your cameras so we can see you for the Q&A portion. It's always nicer when you're a speaker to see people's faces. Now, if you have a question or comment, please use the raise hand feature found under reactions in the Zoom and wait to be called, or type your question into the chat and we'll read it if you're not able to unmute, and we'll get to as many as we can. Let's see if there's folks in the chat yet. If not, I'd like, oh, darn, I see Dr. Gopal already has a question. I was going to take the privilege of being the facilitator to ask the first one, but I'll pass it to you, Satish. Please go ahead.
Great. Thanks so much, Ophira, and thanks, Dr. Prabhash, for a really stimulating talk. I actually had a couple of questions. One is, I think, just congratulations. I think it's really remarkable to see such a large burden of head and neck cancer patients in India and at Tata Memorial that support this portfolio of studies that have really helped to advance care for this patient population in the Indian context. So that's really remarkable. And I think so much of the work is so patient focused and centered, trying to really evaluate therapies that are going to have an effect on actual patients' lives, you know, in your environment, which is another thing that I think really want to applaud you for. I guess I had three questions sort of related, if you wouldn't mind. I mean, one is, I'm curious how you prioritize which interventions you know, these trials are quite large, they're quite challenging to conduct, they take quite a lot of time. So I'm just curious what your process is for prioritization of interventions that you think would be most valuable for this patient population to study, given that, you know, resources are always limited. And I wonder if patients are involved, like advocacy groups are involved in any of those discussions. So one question is about prioritization. Given the second question is, it looked like you were using kind of conventional CTCAE and quality of life assessments. And given what seems like an obvious patient-centered and patient-focused effort in so much of your work, I'm curious if you've taken if your group has sought to validate patient-reported outcomes in your context, and including patient-reported adverse events. That may be something to consider if you haven't done, because I think it lines up so well with so much of the work that you all are pursuing. So first question is about prioritization of trials. Second question is about patient-reported outcomes. And then third question, I'd be really eager to hear where you may be going with low-dose immunotherapy studies in the future, including other disease areas, other settings, context, even within the head and neck cancer patient population, because I think, you know, the types of studies that you're doing are going to have a lot of implications worldwide, well beyond India. So prioritization, patient-reported outcomes, and then where you might go next with low-dose immunotherapy studies. Thank you so much.
Thank you, Dr. Satish. So the first question, how do we choose those questions? Primarily, this is OPD based. Sitting with the patient, gives you lots of these questions, and discussing with your colleagues. So we have a head and neck DMJ group where we do have a discussion, and also when we see those patients and you do feel helpless, and then that is where you get back to the question. And like, for example, the borderline resectable patient, we used to see them on the regular basis. And that is where we started saying we need to have some solutions for them. And same way, cisplatinum ineligible patients. So primarily we decide based on the clinic, what we see, that is more of a clinic driven, where we see that patients, where there's an unmet need is pretty obvious. Coming to patient advocacy group, it is not so popular at present, in our part of our world. There are some of the group which are there and they are pretty active, not very actively involved. But yes, patient feedbacks are there, when we make a decision, because developing a treatment which ultimately patient doesn't take has very limited value, and that usually we don't embark upon, and that we are always conscious about that whatever we develop, the patient should be able to take it. Coming to the second question, that was, can you just remind me the second question, Dr. Satish? PRO, okay, I remember that. Okay, the patient-related outcome. So we we do have a quality of life data, in fact, for almost all these studies, and I didn't have time to present it. And those quality of life, URTC or FACT, they are validated in Indian population. But I think so what you were hinting more towards India-centric short quality of life or PRO related, which should be developed. That process is on. As on date, we don't have it. Usually we take what is there from Western world, we validate it, translate it, and then we use it. And almost every of these trials, we do have it. Coming to the low dose immunotherapy protocol, how we are going to take it forward. We are taking it forward. This was something which we were interested. Does it work? That was the first case. So it looks like it has a value. But I need to share something because we have access to some more data. First, low dose immunotherapy 20 milligram with triple metronomic works. Does it work alone? I don't say I have the answer. There's another trial which we are running alone, which is a big trial. We hope that that gets over this year end or next year. And then we will be talking about that. Does it work alone? So low, we don't know what is the real low. We are also embarking upon in lung cancer and breast cancer, and again, trying to see these low dose immunotherapy, which one works. At this moment, these all low dose is a bit arbitrary. And I keep saying, my friends and colleagues, that we were a bit lucky that 20 milligram worked. We had some basis for it, but we also took this dose based on logistics because that is the kind of resources we had. There was some basis, but also those are the kind of resources we had. We will find out what is the appropriate dose for the low dose immunotherapy in times to come. But yes, there is no doubt, whatever dose we are using, lesser than that dose is effective in patients, and we will find out in due course. So we are trying to explore it further.
Wonderful. Thank you so
Dr.
much.
Satish.
Yeah, I think that's your questions. And I will go to Sudha next, and then I'm going to add myself in the mix. I don't see any other hands up at the moment. Go ahead, Sudha, please.
Thank you, Dr. Prabhash. Really inspiring that the effort to look at sort of minimally effective dose as you have demonstrated. So my first question you answered already is, how do you decide how low is low? What is the minimum dose? But the other thing, I was thinking, specifically with head and neck cancer and other cancers, are you thinking of any sort of studies that look at nutrition? Because, that seems to be very important to the quality of life. And you mentioned that there were nutritionists in your team. And I was just curious, what your thinking is in that direction.
So regarding nutrition, we have done some work. And one of the work was that we used to see, and that was initial work, that 50% of our patients, they used to have a significant weight loss, and what we defined like 10% weight loss. And that used to worry us. And we took a very simple approach. So what we did, we took the help of our social worker, got homemade powder where you have lots of protein. You put all those, dals into it, and you will understand that. And those crushed and which packets were made and given to the patient whom, because the patient, they come to our hospital, they stay in the hospital for whole day. They are not able to take food. And with this simple intervention, the weight loss used to be around 50%. They come down to be around less than 10%. This was one of the initial work. Apart from that, we also worked on what do we do with the Riles tube and PEG tube. And one of the initial work was PEG tube, which is commonly used. We did realize not necessarily we need to use it. Majority of the patients, they are okay without having PEG tube, and only some of them they do require. And same true for Riles tube. So nowadays, what we do, the moment you have a 2 kg weight loss, put those tubes, start having significant intervention. Otherwise, don't trouble the patient with all these kind of tubes for them.
Right,
And
right.
it appears that we are able to manage the weight well with these kind of interventions.
No, thank you. The dal powders are always very good. Even
I
that's
deliberately
really-
use that dal as a word here.
Oh, yeah.
because you could-
no, that's understood. Thank you.
I think by many of us too. We have about 10 minutes left, and I'm going to take the liberty now to ask something. There was a really nicely written accompanying editorial in the paper of the immunotherapy metronomic chemo study that I'm sure you've read. I don't know if others here have read. I'm going to put it in the chat, called Cost Savings and Increased Access with Ultra Low Dose Immunotherapy by Aaron Mitchell and Daniel Goldstein, who are sort of thought leaders in this space. Have you had any, with respect to what they wrote, which was very complimentary and really just asking some of the questions that Satish just asked, and also drawing attention to the great need for better access in terms of, either reducing price per unit or decreasing the amount of unit patient needs, or both, or whatever. Have you had any pushback that in any way and I think you, based on the expression on your face, think maybe you have, and at the same time, a lot of people asking you, how did you do this? Because there's the need everywhere in different tumor types, et cetera. Thanks.
So first, the most important aspect, how we did it, that's primarily because of there is a continuous endeavor at our hospital, and I'm fortunate to work here, and especially my colleagues around, which I showed, some of them, that how we develop those treatment which is useful for our patient, and including our director, Dr. Budway. I'm sure you would have met him. He continuously pushes us that give me good solutions to our patients. So that continuous endeavor remains. Now, coming to how did we do it? Sure, we had the discussion, we made the protocol. That was relatively not so tough part. The tough part was, how do you get the resources? And that was tough. So we had the help from Tata Hospital, and it was supported by a NGO who supported this endeavor. And that led to this trial to be completed. So Dr. Budway, my colleagues, and especially specific that NGO, and I have mentioned that NGO in my acknowledgement. They didn't want the name, so I have not written the name, but the NGO name is there who supported this endeavor. Now, coming to pushback, yes, you do have pushbacks. Thankfully, we have the culture in Tata Hospital where we do get supported by administration, and especially from my director, that they support us continuously in these kind of endeavor, and we don't get involved into those pushback. Because these all trials are owned by the hospital. We are one of the people who are delivering these trials, and also the support of our colleagues, which becomes very important. So yes, when you do this endeavor, it does become a bit of a challenge in those, when people have different ideas.
Thank you. I see there is another question. This is the Geraldina Dominguez. Please go ahead.
Hi, thank you for such an interesting talk. I was just wondering, I saw that in some of the data that you presented, some of the patients were HIV positive. I was wondering, first, is the number sufficient enough, particularly those that receive maybe immunotherapy? Was there any differences between those that were HIV positive and HIV negative?
No, I think so. I presented the data for nimatuzumab, that is a EGFR antibody, which works on EGFR receptor, and that is HPV negative patients. And in that study, overall, that study was positive for progression-free survival and disease-free survival, but negative for overall survival. For oropharyngeal cancer patients, in any way, for that study, we had a biomarker study going on. So we had a HPV data for most of the patient, especially for oropharyngeal cancer patient. and we did the subgroup analysis in HPV negative patients in oropharyngeal cancer and compared chemoradiation with nimetosumab compared to chemoradiation without nimetosumab, and it appeared that chemoradiation plus nimetosumab improved overall survival. But I did add, and we have put in our paper also, that this is a hypothesis generating data in this setting. So
Right, I
this is
think-
not for HIV, so maybe.
Right. I think the point there about the HPV, the epidemiology of head and neck cancer being quite different in different settings, is it?
I guess so.
Okay.
All these patients were HIV negative. Is that correct?
Yes,
Okay.
absolutely. For HPV, yes, in the same paper, we have mentioned, and because biomarker study was there, which is a separate publication, HPV rate is far different. And in the Western world, when oropharyngeal cancer, where HPV rate is 60%, 70, 80, the kind of data you see, for us, it remains around 20%. And non-oropharyngeal cancer, the rate is far lesser. So if you take oral cavity, hypopharyngeal cancer, or larynx, this is in single digit and in fact, low single digit. And that also is part of, again, the biomarker part of this paper, which I presented for nimetosumab study.
So in the last couple of minutes, if there's any remaining questions, I don't know, Satish, if you had anything else to add or any questions. If not, go ahead, please.
Sure. Well, just if there's time for one more question. In the low-dose immunotherapy, I know most of the cases are HPV negative. Did you have an HPV subset, and do you have any sense if the immunotherapy approach works differently or better or worse in HPV positive versus HPV negative patients in your population? Do you have a sense?
There are too few,
Yeah.
doesn't look like there is an interaction, but I do know there is international data for both, that there may be interaction, there may be not. In our, we are not able to conclude well, at present, with the data being pretty small.
Thank you.
I'm going to sneak in one more question then. I noticed in the trial, the gender breakdown between men and women was notable, as it is in many head and neck trials, for being almost exclusively with a few patients who are identified as women. Is there any effort to increase recruitment and participation in trials? Because I know head and neck cancer, especially in the Indian context, in non-HPV related head and neck cancer, it's one of the top cancers in women as well, correct?
That is true. One of the, yes. Yeah. So what I understood that, the question from your side was why there was a disparity between the number of male patients getting included as compared to female. First, absolutely a fair question. So it is one of the commonest cancer, but it comes below breast cancer, cervical cancer, and lower down. So head and neck cancer is not as common in female as compared to male. But yes, there is a bias, cultural bias for patients coming to the hospital, and unfortunately, that bias is there for as far as the female is concerned. Your suggestion is important that there needs to be a far fairer representation for female in this. So as far as the representation of number of patients who gets and a percentage of patients who gets registered and represented, that is similar. But how many gets registered and do we miss it? Yes, there is a concern there.
Thanks so much. And thanks so much for an absolutely fantastic, outstanding talk. This concludes our session for today and our series for the year. A very special thank you again to Professor Prabhash and to all of you for joining us today. And don't forget to join us for, well, it sounds like this is the last session, but we have one in July, so I'm confused. I think we do have one in July 13th. It's on the screen, on cervical cancer prevention and control in China. And once again, please visit our website, cancer.gov/global health, to find additional information about upcoming sessions, past recorded sessions, funding opportunities, events, news, and more. And follow us on Twitter at NCI Global Health. And also we're now on LinkedIn. Thanks very much.
Thank you. Thank you. Thank you so much for the opportunity.